Hello, good afternoon. I think 5 minutes have passed, so we'll start. I will not waste any more of your time. Okay, just checking it works. Okay, so my name is Yusuf. I'm a Pediatrics R1 resident in KHMH, and I'll be speaking about this case that we saw. It's a bit interesting. It came with its challenges, which we'll discuss later on. And this is not a teaching session, it's just sharing an interesting case. So, he's a 10-month-old boy. He is a Qatari visiting Bahrain, past medical history of G6PD, antenatal history is insignificant, is a full term appropriate for gestational age, SVD, no complications, and since birth until showing up, until presenting, sorry, there were no complications. He's not on any medications, and he's fully vaccinated. So the first visit was on the 30th of December. He presented with 2 days of high-grade fever, cold and cough. There was a rash on his arms, and his feeding and activity were normal. However, there was excessive crying about 1 hour prior to presentation. I think this is typical for most cases we see, especially during the season, the flu season and the RSV season. Um, so we've done the examination, and his vitals were normal. He was afebrile at the presentation, and he was well hydrated. There was a bit of an erythematous rash around his nose, upper lips, and it was blanching, non-tender. Again, it's very typical to see these with viral illnesses. Both ears had some dull tympanic membranes with peripheral congestion, and he's had a stuffy nose as well. There were no ulcers, and there was a slight congestion in the pharynx. Respiratory was clear, except for conductive sounds. Cardiovascular is clear, and the abdomen soft, non-tender. We also noticed that he had two papillovesicular lesions, one on each hand, but there was no rash on his legs or the feet, and there was no oral lesions as well. So the only labs we've done was a respiratory viral screen. COVID, influenza A and B, RSV all came back as negative. Again, we see a lot of these cases in the clinic. So I'm presenting.
Hungry?
Yeah.
You want to sit down or any other system free? No. Okay.
Yeah. Okay. Sorry about that. It was a typical acute upper respiratory tract infection, typical symptoms. However, due to these small lesions, there was a small suspicion of hand, foot, and mouth disease. So this was the ICD-10 diagnosis given by the consultant who saw him, and then the plan was supportive treatment, advice, and safety netting. Child went home, presented again the next day. Less than 24 hours later, their parents were concerned about a high-grade fever that's persistent. It's not coming down with antipyretics. And now there was an erythematous macular blanching non-pruritic rash. They noticed it on the morning, initially on the face and then into the right upper limb. Last dose of paracetamol was given 2 hours before presentation, but still maintaining good activity and eating and drinking well. He was having high-grade fever spike of 40.8 when he presented, but still maintaining good oxygen saturations on room air. He was alert, fussy, febrile. There was the nasopharyngeal congestion as presented earlier, and then the rash as we spoke about. So far, still typical case, nothing concerning apart from the high-grade fever that's persisting, but there was no clear indication for admission. We've not done any labs, and the assessment this time goes more with an upper respiratory tract infection with a viral exanthem and the ICD-10, as you can see. So what we gave was some tepid sponging, brufen, and the fever actually went down in PTU. So we advised the parents and reassured them that this could be a typical viral illness course. It can take 3 to 5 days, but the child should have some fever-free periods and should be more active during these periods, and we gave them the red flag symptoms and when to come back. So again, one more day later, they presented one more time. It's the beginning of the year this time, again with a high-grade fever that's persisting. And this time presented with a generalized rash. Started on the face, as we said before, and then spread to his trunk and extremities. But by the time we saw him, it was fading. There's also bilateral conjunctivitis with yellow discharge, and he started to develop a cough that's persistent and worsening, and you could hear his voice change now. Obviously a runny nose, and now he is having reduced oral intake and reduced activity along with loose stools. They were green, they were watery, they were approximately 1 to 3 times a day, and no blood, no mucus. 3 visits in 3 days, and the symptoms are worsening. Now it's requires a little more attention. On examination, we gave him antipyretics. He was a bit afebrile, temperature as you can see, and we gave him IV fluids. Then he got well hydrated. Before that, he was showing a bit of cracked lips and dry mucous membranes. Bilateral conjunctival redness, as we said, but there was yellow discharge present, and he also had a congested throat and conductive breath sounds. Cardiovascular and abdomen is normal. There was erythema on the extremities, but there was no peeling. So now we're thinking that we should manage it a bit more differently. So we started with the labs. We did a CBC. This was the result of the CBC. HP is a bit low. He's known G6PD. Other than that, white cell counts is fairly normal. We move on to CRP. It's high, as you can see, it's 141. PCT is 11.2, which is elevated. Stool microscopy. And we're thinking adenovirus. It's turned out to be negative in the stool. We've done a chest X-ray, showed accentuated bronchiovascular markings. So now we have a few more diagnoses in our head. It could be an upper respiratory tract with enteritis and poor oral intake. It could be an adenovirus infection. It could be an evolving Kawasaki. So our plan was to admit for IV antibiotics. We started him on ceftriaxone, supportive treatment, and close monitoring. Okay, I'll just check if it's still working. Okay. So, on day 4 of the illness, which was the first day of admission, despite antibiotics, still the fever is persisting and the diarrhea as well. And the child is still irritable, fussy, poor oral intake, and looks generally unwell. By the end of day 4 and start of day 5, he's received 2 doses of IV ceftriaxone. But on day 5, he was still febrile, lethargic, with poor feeding, and we've repeated the labs. CRP went up to 211, PCT now came down. We decided to add proBNP because there was a suspicion of Kawasaki disease, and the proBNP has increased. I mean, it was high, sorry. The albumin, as you can see, is fair. So now, after these labs and the high-grade fever that's non-remitting, there was a high suspicion of Kawasaki. We asked for a cardiology review. The cardiologist kindly did an ECG, came back as normal, and we made the decision along with the cardiologist to treat as incomplete/atypical Kawasaki disease. So on day 6, finally, we are able to start the IVIG. I say finally because it was supposed to be started on day 5, but we came across some complications, which I'll speak about later. IVIG, 2 gram per kilogram over 12 hours, and aspirin and methylpred. So we started with methylpred while getting the IVIG ready. So during I'd say after 3/4 of the IVIG, while it was ongoing, the child started to show noticeable improvement. His fever resolved, his activity improved, he's less fussy, less irritable, better oral intake now. So we continued monitoring. On day 7, he's now been afebrile for more than 24 hours. Improved feeding and activity. His rash and conjunctivitis have almost gone. And we changed his aspirin to clopidogrel as he's G6PD, and switched to oral prednisolone as a reducing dose. We're titrating it down. So day 8 was the recovery phase. He's been afebrile more than 36 hours. He's clinically stable, active, well hydrated, parents happy. He's back to normal activity. He's socializing, pleasant now. CRP coming down, pro-BNP is coming down as well. The blood cultures were negative, eye swab cultures negative, stool cultures negative. It's worth mentioning that the loose motions resolved as well. So now we were fairly confident in discharging this child. So discharged home with a cardiology follow-up arranged and a planned echo schedule as advised by the cardiologist in 10 days and then 6 weeks and then 1 year. So this is a case of atypical/incomplete Kawasaki disease. And the classic Kawasaki has to have a 5-day fever that's high grade and any 4 or more of these clinical signs. However, this patient did not have 4 or more. He had the fever, but by the time we saw him, still wasn't 5 days yet. But by the time we started IVIG, it was 5 days. And bilateral conjunctivitis, however, there was a discharge from the eyes, which would muddy up our thinking about the Kawasaki diagnosis because typically it's without discharge. There was a polymorphous rash, and then the lab markers, they were the determining factor as well. So this is just a mind map about suspected Kawasaki disease. It's from UpToDate. It's really helpful when you're stuck thinking about atypical cases like this. And if you follow along with the diagram, you would see that you'd end up with suspected incomplete Kawasaki disease. So I spoke earlier about the challenges we faced. The patient being from Qatar, living in Qatar. They came here to celebrate with their family, and while they were here, there was indecisiveness and hesitancy about whether to stay for the treatment or to go back home. Our job as physicians was, or it's always is, patient as the priority, the patient's safety. So we explained to them that, and then the severity of the illness, and how the child could deteriorate while on the way back home. It would take approximately 5 hours. Still, they needed multiple conversations, and we showed them the lab results in order for them to make up their decision. This indecisiveness is obviously part and parcel of our practice. We have to speak with the parents and convince them. However, in this case, it was delaying our treatment. That's mainly because of their communication with their doctors back home. For even the slightest of interventions, medications, cannulations, they would ask us to hold on and wait while they would speak with their doctors back home. And as you can imagine, that would cause quite a lot of delay, and decisions made during the day by the day team would often be delayed until the night where there is minimal staffing. There was also one incident about the IVIG where we made up, or we as a team, collectively came up with the decision to give IVIG after doing the echo. The echo was done at around the afternoon, but then the IVIG was delayed until midnight. The reason for the delay was two things. Parents were still consulting their doctors by the time they gave us the go ahead, because the cannula was out. By the time they gave us the go ahead to give IVIG and put in the cannula, it was around 8 at night. And around that time, the nursing staff on the ward tried to cannulate but failed. And then the nursing staff in the emergency came up and tried to cannulate but failed, prompting us to call the anesthetist, who came and had a look. He was not the most confident, tried also with the ultrasound scan, and couldn't get a cannula in. So we were stuck now, who to escalate to, as it was quite busy downstairs, and the doctor in the emergency could not go up and to attempt cannulation. Yeah. After that, we waited for the shift change until the new doctor came in, and thankfully they were able to cannulate. During this time, the parents were advised that we'd need monitoring to give IVIG, make sure that the child is safe. So we had two options. We have cardiac monitors in Ward 3A, and we have the ICU. From our point of view, as doctors, I don't think we should be involved in this, but for some reason, I think there was miscommunication, because when we got to the parent, they were frustrated, they were angry, and yeah, they just were screaming at the top of their lungs at us. What's the word? Just telling us about their frustration. They were told that there was no room available on the ward, but then they'd have to go to ICU, and they were not told about the price difference. So when the parent went to the ICU, had a tour, agreed, then he was faced with the price difference, which he disagreed about, and he said, "You're giving the treatment, might as well just give it here." So this was also a point of delay. Thankfully, this time there were no complications immediately by the delay of IVIG, but maybe next time, hopefully not, there might be some complications due to these delays. So thank you for listening, and if you have any input about what could have been improved, especially about these delays, these miscommunications, these admin issues, it would be greatly appreciated.
Thank you so much, Dr. Yusuf, for a well-presented case with all the details, including the challenges we faced administrative. It's just that I was in and out. It's a busy outpatient and emergency here. So the forum is open for any questions.
What was the platelets? Platelets were 369.
I had just one comment to make, is that actually I saw this patient the first visit. For me, clinically, it looked more like hand, foot, and mouth disease, high-grade fever, otherwise well-looking child with some few vesicles around the mouth and hands. So it clinically, first presentation, it seemed like an evolving, like a hand, foot, and mouth. But the mother messaged me and she said high spiking fever. So I asked her to come back again. So I think second visit also he was sent back. Third visit he was admitted. Now, of course, there were a lot of difficulties and challenges with respect to the child not being from here, and they had their own fears, maternal anxiety. Apart from that, we do have clinical criteria for Kawasaki's, but then we had to take a step in and suspect Kawasaki on day 4 of the fever because of his clinical picture and his lab tests. He had bilateral purulent, bilateral conjunctivitis. The only thing was this had discharge. That was one not in favor. But he had high spiking fever. He was already on antibiotics, but not responding to it. His CRP was spiking up high, and the second CRP actually went up higher than the first. I think the first was 140 something, the second went up to about close to 200. And uh, he didn't have very many other typical features of Kawasaki's, but we had to step in. Unless we have a high index of suspicion of Kawasaki's, we will not be able to pick them up. The main thing, the main reason for us picking up Kawasaki's and investigating further and treating is to avoid the complication which is dreaded, the coronary aneurysms. And so this boy was on the cusp. He didn't complete 5 days of fever. It was only 4 days, but he had most of these other features suggestive. So it was good that we went ahead and investigated and finally had to treat him. Although good that the echo did not pick up any coronary aneurysms as such, but he's of course on a follow-up. So sometimes they can present atypically. We don't need to wait for the textbook progression and manifestation of all the symptoms. I think a high index of suspicion and investigating, because pro BNP was in the 2000, close to 3,000 it was.
Yes.
Yeah. Thank you.
Thanks, doctor.
Any more comments, any questions?
Hello, hi, Dr. Yusuf. This is Dr. Athar here.
Hi, doctor.
Hey, I'm not it's not my domain, pediatric, but the cannulation has been a frequent issue in pediatric ward and emergency. So can we ask for a vein detector, which is long due? We are using, I have seen using otoscope, ophthalmoscope, slides. So we should use this opportunity. It's very frequently cannulation delay, as you have mentioned in detail about that part. That's why we have presented, but we are not discussing the solution of the problem. You conveyed the information, but although it is not my domain, but still nobody is interested in finding a solution. So case presentation was good, but we should come to a solution. What should be done to these things not to happen. And also recently, as far as I know, there is nothing although it is separate, there is no method to give respiratory support in the pediatric ER and to maintain temperature. I'm bringing it very frequently. But for this case, we should sort out a method to get a vein detector. And also, as far as pediatric ward is concerned, there should be a proper treatment room or therapy room where proper cannulation with proper light source should be arranged. That is my opinion. I'm not involved in pediatric patient, but this is what I have seen in pediatric ward all over the places. Thank you.
Thank you so much, Dr. Attar. That's exactly what the issue was. Unfortunately, it's a recurring issue, and I second your opinion. I cannot agree anymore. The methods we see here of vein finding, to be honest, they are a bit outdated, and by having the technology available, I don't think that as an institution that's as good as this one, that we don't have it here, which creates issues. Thankfully, this time it wasn't a major issue, but who knows next time what might happen. So any help, vein finder, or maybe a dedicated pediatric phlebotomist, any ideas like that would be appreciated.
I think it was timely that Dr. Preeta posted it was of course in the lab, It's an instrument that detects using Doppler ultrasound, detects the vein and collects the blood. It is all machine operated. So I think we should consider something like that for the future. These need to be put up and addressed in our pediatric service line meeting.
Yeah, definitely. Okay, anyone has any questions, any comments, any points of improvement?
One thing is, in this case, there was a delay in advising IVIG, and by the time it was given, quite a lot of time delay. In all these cases, I know there were some challenges. Parents wanted to take their opinion of their Qatari doctor. We should have in place, we should get it signed by the parents that they will be responsible for any delays. So medical legally, we have to protect ourselves. So that's another thing. We see giving them a leeway, waiting for them is one, but protecting ourselves and the hospital is another. In all these cases, we want to give the IVIG now, but there's a delay by more than 12 hours. So that delay has to be accounted for, and they should be held responsible. So that's another thing we should keep in mind.
Yeah, it was one part due to their delay. That was when we had day staff available, but when they made up their mind, it was the night. So less staffing and more difficulty to obtain a cannula. Okay, I think I will end the presentation here. Anyone has any questions and any points of improvement, we'd love to hear that. You can message me anytime. Thank you so much. Thanks for listening. Thanks for your time.
Feedback. Yeah, thank you. And we'll close the meeting.